Okay, first of all, thank you very much, Martin. Thank you very much to the Sequana team for the invitation. In the course of this afternoon, the evidence that is available currently for the use of the pump. So my plan is to present the data from the randomized controlled trials that has been published recently with a classical point, introduction, methods, results, and then I will comment a little bit on our perspective. You are familiar with this concept, but anyway, we are speaking about patients with refractory ascites, which is defined as the presence of ascites which cannot be mobilized or which recurs in spite of conservative treatment, which is called medical therapy with diuretics and sodium-free or sodium-reduced diet. We distinguish two types: the diuretic resistance ascites, which is a lack of response to medical therapy at a maximal doses, and a diuretic intractable ascites, which is ascites that is associated with diuretic-induced complications, so we cannot increase the dose of diuretics. When cirrhosis is diagnosed, some patients have no ascites, some have ascites, and some have refractory ascites. And you can clearly recognize here that the survival in these three different populations is profoundly different. We have 6% per year of patients developing ascites and around 10% per year of patients with ascites developing refractory ascites. And this is the group of patients that we are treating with the alpha pump. So consider that this is a very fragile population. The treatment of refractory ascites consists basically in repeated large volume paracentesis, which has the advantage of a low incidence of complication. This is very rare. This is associated with a rapid relief of symptoms. However, the drawbacks are that some patients develop the so-called post-paracentesis circulatory dysfunction, which is associated mainly with kidney dysfunction. It has to be treated or substituted with albumin. There is a somehow decreased quality of life because these patients have to be punctured every week, every second week. And there is, of course, need for infrastructure because you cannot treat these patients at home. A second possibility is the placement, the insertion of a transjugular portosystemic shunt. The advantages are a better survival, and you see here that patient treated with this stent between the right branch of the portal vein and the right hepatic vein, the prognosis is, or the survival is better compared to repeated large volume paracentesis. Symptoms are relieved, of course. There is a reduction also of variceal bleeding and hepatorenal syndrome because this system is associated with a decrease in portal pressure. However, there are also here some drawbacks. The success is limited to 50–60% of the cases. Patients can develop hepatic encephalopathy. TIPS doesn't work always very well. And if there is portal vein thrombosis, the insertion of a TIP is possible but very difficult. For these reasons, alternative treatment have been looked for in the past. You see that the first ideas were developed in the 70s, and this is an example of a Levin shunt. There was a Denver shunt. Basically, the idea was to take the ascites liquid and to shunt it into the venous system, and this was a kind of pump. And in the 90s, an idea has been developed to shunt the liquid in the abdominal cavity into the urinary bladder. And you see here one of the first publications about the possibility of using this system. And the further development of this idea was the alpha pump. The alpha pump is a system consisting in an electrical pump device here connected to tubing. The blue one is aspirating the fluid from the abdominal cavity, and the yellow one is pumping the fluid into the bladder. You see here the dimension of the system. And you see here in a sagittal presentation that the pump is placed subcutaneously. The white tube here, or blue tube here, is the peritoneal catheter, which is actually free in the abdominal cavity. And the yellow one is the bladder catheter, where the acidic fluid is just pumped in. The system is controlled with a so-called smart charger, which charges the battery here and also takes up data. And data are selected and sent through a so-called direct link system to the physicians who are taking care of these patients. So the first data that have been collected comes from the PIONEER study, which was an open-label, single-arm, uncontrolled study. You see that for the first time, the efficacy of the pump was clearly demonstrated, with a number of paracenteses decreasing dramatically after the implant of the alpha pump. You see, however, that the study was divided in two cohorts, and the first cohort was characterized by the presence of a very high frequency of complications, spontaneous bacterial peritonitis, renal dysfunction, hepatic encephalopathy, infections, and you see here the numbers. After some adaptation or optimization of the protocol, and in particular the introduction of a prophylactic antibiotic and some technical adjustments, you see that in the second cohort of patients, results were clearly better. So the conclusion was that the system was safe and effective. However, there were no control data. And for this reason, today we are speaking about these randomized controlled trials. The design of the study was a multi-center, open, randomized, and controlled trial in 6 European centers. 60 patients have been included with refractory ascites, and these patients were randomized to either treatment with the alpha pump or standard of care with repeated large volume paracentesis. The primary objective was paracentesis-free survival, defined as the time to first large volume paracentesis, defined as a paracentesis of more than 5 liters. Secondary objective were cirrhosis-related complication and survival, and there were also some exploratory parameters, quality of life, nutrition, and need of repeated paracentesis of all kind of volumes. There were 81 patients who were assessed for eligibility. 21 were screening failures for logistical reasons, for infection, and for other reasons, so that 31 patients were included in the large volume paracentesis group and 29 for the alpha pump treatment. Of these 29, 2 were excluded because of obstructive uropathy and left inguinal hernia, so that the final data concern 31 patients with large volume paracentesis and 27 for the alpha pump. There were some reasons for discontinuation. In 10 patients, withdrawal of consent, loss to follow-up, liver transplanted in 3 cases, or death, and this was in the paracentesis group. And also 10 patients in the second group, the investigator decided due to adverse event to interrupt. 3 patients were transplanted and 5 patients died, so that at the end of the study, we have the data of 21 patients in the paracentesis group and 17 patients in the alpha pump group. The populations were very well balanced and comparable. You see that the age was around 60, a predominance of male patients, a little bit overweight. They were not very sick, like many patients with refractory ascites, but with a quite conserved liver function, males around or between 11 and 12, and also a child B8 to between 8 and 9. A majority was B, with a few patients child PUC. The majority had an alcoholic-induced cirrhosis, and you see that the time since start of paracentesis was 1 year, so a long period before implanting the pump, and a considerable number of patients had been already hospitalized in the 3 months previous to the inclusion in the study. Coming to the results, the main thing, and of course the main aim of the study was to demonstrate this, and this is the proportion of patients without large volume paracentesis, and you clearly can recognize that the red line corresponding to the patients treated with the alpha pump was doing clearly better compared with the control group. This is no surprise, but this had to be demonstrated in a controlled setting. The number of paracentesis, and we speak of large volume paracentesis, was clearly higher in the standard of care group compared with the alpha pump group. And also the total number of procedures was clearly different, with 30 in the alpha pump group and 268 in the standard of care group. Why was large volume paracentesis necessary in patients treated with the alpha pump? Well, there are 2 main reasons. There were some pump or catheter related issues. You see here 11 cases in 5 patients, and there were some, well, let's say problems, but we may discuss it later on, with the planning, with the programming of the pump, which was programmed to pump at a volume that was too low compared to the needs of the patients. There are some other reasons. For example, you can see here that in one case there were catheter-related problems and infections. So coming up to the albumin levels, the protocol was designed without the automatic substitution of albumin in the alpha pump group, while patients treated with large volume paracentesis were treated according to the current guidelines. And you see that on the left side, the change in albumin over time was not very evident, but if we look at the change in albumin from the baseline over time, you see that the group of patients treated with the alpha pump had a significant decrease in albumin. Whether or not this is, of course, mathematically this is significant, but whether or not clinically this has somehow a significance remains to be discussed. And you see here on the right side the albumin supplementation for patients. Here were the grams of albumin given per paracentesis, of course higher in the control group, and here the cumulative dose also higher in the control groups. Concerning the kidney function, here we have some very interesting results. You see on the left side the change in creatinine over time, and on the right side the change in creatinine over baseline. And I would just like to draw your attention to the initial phase, where the creatinine level in the group treated with the alpha pump tends to increase, but over time this is not the case, and you can see here that there was actually no significant difference. Acute kidney injuries was considered with an onset of 2 days, and when serum creatinine doubled from the baseline, and these are normal criteria that are routinely and currently used. If we go in detail about the characteristic of this kidney injury, you can see that in the alpha pump group, the majority of the patients have a stage 1 AKI, and only 1 patient at stage 2. There was only 1 patient who recovered with sequela. There was, however, 1 patient who died, and there was 1 case of hepatorenal syndrome of type 1. In the standard of care group, there were a little bit less patients, however, in stage 1, and only one in stage 2 who recovered with sequelae. This means that the most episodes occurred in the first 7 days after the implantation of the pump, as I showed you in the previous slide. 15 out of 19 episodes and 23 out of 30 total episodes of renal insufficiency in the pump group were associated with a full recovery. And as mentioned, one subject in the alpha pump group died. This is here. Hepatic encephalopathy was not a concern. You see that, well, the numbers are, of course, very low. There was 1 patient of overt hepatic encephalopathy in the alpha group and 2 patients in the standard of care group. This was not significant, but the number, of course, is very low. And interestingly, there have been in a subgroup of patients an evaluation concerning the nutritional state of these patients. You see on the left side the mid-arm muscle circumference with the absolute data here and the difference between the beginning and the end of the study. And you have on the right side the hand grip, also here in absolute data and in relative data. The message is, I think, quite clear. You see that in the alpha pump group, the mid-arm muscle circumference is clearly increasing in contrast to the standard of care group. And you also see here a difference in terms of muscular force as measured as by hand grip. And as far as the significant or serious adverse event, we have very different possibilities. You see that as a general observation that the incidence was in 85% of patients and 45% of patients in the standard of care. And you can see that the majority of the problems were renal or urinary disorders related, and also infections were somehow relevant, whereas there was also other complications that occurred in a lower frequency. And if we look into a little bit more details, the complications related to infection, you can see on the left side all kinds of infections that have been recorded during the study. The majority were classified as adverse events. There were, however, some serious adverse events. However, there were no difference in peritonitis or urinary tract infection between the alpha pump and the standard of care. And in 2 cases, pumps were explanted due to infection or urinary tract infection, which is in reality what is important. And in all patients, also here treated with the alpha pump, there was antibiotic prophylaxis with norfloxacin or ciprofloxacin. Reinterventions were in some cases necessary. You see that there have been 9 reintervention, and here you see the time to intervention after the implantation. The problem were lack of communication, a problem with a bladder catheter, which is, well, we can discuss about it, but which is actually very rare. A problem with a peritoneal catheter, dislodged migrated blood, etc. And the system had to be explanted in 3 cases due to wound infection or wound dehiscence. We are going to see some pictures of these problems in the presentation of Dr. Stoney later on. No subject discontinued due to device deficiency or need for reintervention, and 6 reintervention were performed for device-related reasons, and actually this was easily corrected. So there were problems, there were more problems in the alpha pump group, but there was always a solution for these problems. The survival curve clearly shows that there was no difference in terms of survival. So we can discuss whether or not, or despite more complications or an higher incidence of complications, survival was the same. So what about the case or the scenario if the rate of complication would be the same between alpha pump and standard of care? We can discuss about this later on. And one last point that I would like to focus on is the quality of life. You see on the left side the chronic liver disease questionnaire. In orange, the alpha pump patients. In blue, the large volume paracentesis group. You can easily recognize that the increase in performance is more related to the orange group. And this data have been also confirmed with another questionnaire, SF36, where you see that there was, in general, an improvement compared with the standard of care group. In conclusion, the alpha pump was independently associated with a better quality of life. However, only at 3 months. The data at 6 months do not confirm these differences. So what can we conclude from this data? First of all, this study confirmed safety and efficacy of the alpha pump in reducing the need for paracentesis with no incremental risk of infection and impact on survival. The alpha pump significantly improved the nutritional status of patients. A transient and reversible acute kidney injury was observed after surgery, so in the early phase after the implantation. Device deficiencies were minimal and easily mitigated, often associated with charger issues, low program pump volume. So things that we can improve and correct. The take-home message that I would like to give to you today are that the alpha pump implant procedure confirms to be a safe intervention. The need of large volume paracentesis is significantly decreased, so these data are confirmed and strengthened. Beneficial effects on quality of life and nutritional status have been observed, and complications may occur, of course, and there is place for improvement. What is the perspective, and what are for me the open questions in this situation? Can kidney dysfunction be ameliorated by reducing the pump volume? This is, in my opinion, an issue that is still open. Should albumin be administered in patients with an alpha pump to improve their performance? And certainly more data are needed as far as nutrition is concerned, tips, the quality of life, patient selection criteria, this is a critical issue, and the use of beta blockers that was not addressed here. I summarized the details of this publication that is available online, and for further information, I can give you an answer if I can, otherwise we will go back to this publication. I'm done. I thank you very much for your attention, and if you have any question, I will be happy to answer you. Tips, the quality of life, patient selection criteria, this is a critical issue, and the use of beta blockers. Don't have any discussion after the presentations. Okay.
Okay, so I'd like to start with the second presentation. Thank you very much for giving me the opportunity to present the data of the PMSR study. This is the post-market surveillance registry in comparison to what we just heard about the randomized controlled trial. This is a real-life collection of data, so this is not in a fixed study framework, but as a collection within a registry. This is just to give you a brief overview of what kind of studies have been performed. So the first feasibility study was done in 2008, and then in 2010 the Pioneer study was started. And what we just heard, this was the randomized controlled trial. This trial started in 2012, and the same year also the post-market surveillance registry started. And the intention was to include at least 100 patients. 100 patients that are cirrhotic. So what is the aim? The aim of this registry was to assess safety and efficacy of this treatment in patients with a contraindication to TIPS. So we just heard about the function of a TIPS, so I will not go in more detail regarding TIPS. What was the primary objective? It was safety. So the idea was to learn more about safety, how safe is the alpha pump, and the observation period was 24 months. There were also some secondary objectives. Those objectives included clinical performance and impact, so ascites transportation and the requirement of paracentesis. Then analysis of the log files that are automatically generated. Then clinical status and laboratory results, and also clinician and patient questionnaires. So first I'd like to summarize the baseline characteristics. In this analysis, 56 patients of 100 patients were included. Median age was 62 years, range 50 to 78. Patients were predominantly male, so 77% male. BMI was around 26, at the border of overweight. And the etiology here was not different to the other trials that have been done. Most patients suffer from alcoholic liver disease. These were 70%. And some patients had hepatitis C, some NASH, 1 or 2 patient cardiac disease, autoimmune, drug-induced hepatitis B, and autoimmune and hepatitis C, B, and alcohol have been observed in 1 patient each. How sick were these patients? What we can see here is that the patients included into the registry were a bit sicker, so they had more advanced liver disease than those investigated in the randomized clinical trial. Here, mean Child-Pugh score was almost 9, and 2/3 of patients had a Child-Pugh B, and 15% Child-Pugh C stage. MELD score was also a bit higher. If you remember, it was around 11-12 in the RCT, and here it is 13.6. So this means that we are dealing here with patients that are a bit more advanced and also a bit more prone to complication due to their liver disease. So this slide shows you disposition at data cutoff. So patients were observed for a maximum of 24 months. But for this analysis, we included patients who had a follow-up of at least 12 months. And at data cutoff of these 56 patients, 3 were still on treatment. This means between months 12 and 24. 3 patients completed the study. They had a 24-month follow-up. 9 received a liver transplant. 1 patient did no longer require the pump because of good evolution. Then 17 patients were withdrawn due to SAE. Of these 17, 7 died later on, 7 recovered, and in 3 patients the outcome was not known because these patients were not followed after the explantation of the pump, and due to this, in some patients, it was impossible to find out the reason. Overall, 23 patients deceased on study, and 7 later on after the explantation of the pump. We had a median follow-up of 5.8 months and a mean follow-up of 8.3 months. So the main point is situs transportation, and here you can see how often these patients needed a large volume paracentesis before the implantation. So these patients needed 2.8 paracentesis per month. This is the mean before the implantation, and this dropped to 0.28 after the implantation of the pump, and that is comparable with what we know from the PIONEER study and also what we know from the RCT. So the pump is highly effective regarding transportation of ascites. What about the volume that is transported per month? Before the implantation of the pump, it was a bit less than 20 liters. This is the mean. And after the implantation of the pump, this increased to 26 liters. This has been observed in other studies as well, and it's not entirely clear whether this is due to progression of the liver disease or whether this really has to do with the pump. We stay with paracentesis, and what you can see here on this graph is that most patients did not need a paracentesis after implantation. 7 patients had 1 large volume paracentesis, 2 had 2 and 3 each, and 8 patients had more than 4 large volume paracentesis. An important question is, why was a paracentesis necessary after implantation of the pump? Because basically the pump should do the job, but sometimes there were pump or catheter related issues, so this was half or 44% of the reasons. Then sometimes there was a charger problem or insufficient charging. This, of course, is also an instruction issue. Usually we can handle this without a paracentesis, but just by instructing the patient to do it correctly. Sometimes we also observed the programmed volume that was too low for the ascites production, and this also reflects a bit the study and the time frame it was performed. So at the beginning there was less experience with the pump, later on people were more experienced, and this is basically something that should not be a reason for a large volume paracentesis anymore. And in some patients it was basically not known because the pump was functioning well, and it was nevertheless performed a large volume paracentesis. Now we're coming to the survival curves. On the left-hand side, you can see the overall survival of patients, including known death after pump explant or withdrawal from study. And what we observed here was a mean actuarial survival of 12.8 months and a median survival of 9.8 months. And this is within the range that also has been observed in other cohorts, independent of the alpha pump, but with the same disease. On the right-hand side, you can see pump system survival. This is the technical survival of the pump. And what we can see here, that the survival is 24 months maximal, and the mean pump system survival was 13.6 months. An important question is to analyze why patients die, if they die having a pump or after the explantation of the pump. And what we can see here is that half of the patients died due to the liver disease, so progressive liver disease. A significant number of patients also died due to sepsis or infection. These were 6 patients, it's 20%. Some had renal failure, and the other etiologies were less frequently observed. There was one positive bleeding, hepatocellular carcinoma, stroke, ischemic heart disease, and in a few cases it was not known. So what we have seen, this system is highly effective, so it does the job quite well, but the question is, are there complications, and if, what are the complications and how can we handle them? And what you can see here is a patient I have treated myself, and the radiologist called me because he was not able to see the problem because he had no idea and no experience with the pump system, and it's quite easy to tell what the problem is once you know how the system looks like. What you can see here is that the peritoneal catheter is disconnected, so there's no more connection to the pump, and the fluid is no longer transported. So this is a technical problem that has to be solved, of course. So in the next part, I will focus on reinterventions, on pump exchanges. This is to take out the pump and to put in a new one, and explants. This means you remove the pump without re-implanting a new pump. Overall, 17 patients required at least one reintervention, and in total, these were 23 reinterventions. 11 patients had a surgical pump replacement, and of these 11, one patient had two or twice an exchange. The pump was explanted in 27 patients, and of these, in 17 patients, the pump was explanted due to a serious adverse event. This table gives you an idea about the reasons for pump explantation. So, as I mentioned before, in total there were 27 pumps explanted, and in 17 patients this was due to an adverse event or a device deficiency. So in one patient the pump was clogged, two patients had macroscopic hematuria, and 14 patients had infection, and this is probably the most difficult to treat patient group, not only because of the pump, but also because of the underlying liver disease. So there were patients with peritonitis, other with sepsis or suspicion of infection, but sometimes it turns out that it even wasn't or hasn't been an infection. There were two pump pocket infections, one urinary tract infection, and one perforated diverticulum. But important also, 10 patients had an explantation of the pump unrelated to SAE. These were the patients that finally received a new liver. They had a liver transplant, and one patient recovered from the ascites and did no longer need a pump. So it was also explanted. This list gives you an idea of what kind of problems we are confronted with having patients with an alpha pump implanted. So there are several subsections here. We have pump dysfunction, we have peritoneal tube dysfunction, bladder tube problems, charger problems, and procedure-related events. And what is very important, and this you can easily see, is within this box, and this has been the most frequently observed problem. This was blocking of the peritoneal tube. In the early days, this was very frequently observed. So here in this cohort or register, we had 21 patients, and this led to re-interventions in a significant number of patients. But the good thing is that now with the introduction of a new catheter, these problems virtually seems to be gone. So we almost never observe this anymore. So this is also part of the history and historic data and problem. The other problems can be observed not very frequently, but from time to time. So sometimes there's clogging of a pump. Humidity might be a problem. communication or faulty sensors. Then regarding the peritoneal tube, there is not only blocking possible, but also dislocation. Sometimes they disconnect, as in the patient I have presented you, or kinking of the tube can lead to no more transportation of fluid. Bladder tube problems are observed not very frequently or rarely, so sometimes there was blocking or displacement. This was observed in one patient each, and never there was a disconnection. So charger systems overall were not observed frequently. Sometimes there was insufficient charging, but then this is an instruction problem and a management problem of the patient and not a problem of the technical system. Then we have the procedure-related events. Ascites leakage, here within brackets it's prolonged because initially after implantation it's quite frequent to have minor leakage of ascites, but this can be handled quite easily by increasing the pump volume, sometimes by additional sutures, but there was no patient with prolonged leakage. Wound dehiscence can be a problem, and if this occurs, it's usually difficult to keep the pump in place because of risk of infection. Outflow tract obstruction, this might be a problem and should be addressed in pre-screening, especially male patients, for outflow problems. Hematuria has not been observed here. When we submitted the paper, one reviewer asked for the outcome after revisions and explantation and pump exchange, and that's why we collected this information. This is 1 month outcome data. We have 3 groups. We have 3 interventions without pump exchange or explantation, so this is usually tube associated or catheter associated. Then we have pump exchange and explantation of pump. And what we can see here is that re-interventions, for instance, due to a blocked catheter, is of course not something you are looking for, but if you have the problem, then it is easy to be solved, and none of these patients died, and the recovery was good in this group. The same is true for pump exchange. Of these 12 pumps having been exchanged, 11 recovered and 1 patient died. A more difficult group is the explantation group, and here of course we are dealing with patients having a serious adverse event mainly, and in this group here a significant number of patients died. Of course, it's always difficult to say whether this is now progression of liver disease or whether it's really pump related, but probably it's both, not the same in every patient. On the other hand, a significant number of patients also recovered, and these were mainly the patients that were transplanted or the one who did no longer need a pump, and also a significant number of patients with an SAE survived. In the last part now, I'm talking a bit about the lab outcome, and what we have seen in this registry is that during the follow-up there is a moderate decrease of albumin. The decrease can be explained at least partly by the losses through the drained ascites, because the protein amount is quite high in the ascites. But it may also be related to less production of endogenous albumin or progression of liver disease. Whether this decrease is finally clinically relevant or not is difficult to say. Another point is that up to the implantation, patients were substituted on a regular basis, and then the substitution was stopped in most of the centers participating. And this is also something that might play a role. What you can see here is the follow-up data of different lab parameters. We have the creatinine here, albumin, INR, and total bilirubin. And we have the data separated for long-term survivors and short-term survivors. And what we can see is that in patients who are short-term survivors, this means less than 9 months survival, there is a more pronounced increase of creatinine and a more pronounced decrease of albumin, and also an increase of bilirubin. But of course, this might also be a selection bias because the patients performing better, they live longer and also have better lab values. The second point I'd like to address is creatinine kidney function. We heard before in the randomized controlled trial, there was an increase of acute kidney problems in the first week after the implant. And here I show some data regarding creatinine. We observed, as in other trials also was the case, but not always significant, an increase in creatinine after the implantation of the pump. What is the reason for that? We do not know exactly. This might be due to a decline in glomerular filtration rate or a combination of relative depletion of intravascular blood volume in the setting of continuous drainage or hypoalbuminemia. But overall, so far, it is not fully understood what the reason for the deterioration of kidney function is. If you're looking at MELD and Child-Pugh scores, then again, we can see that in the short-term survivor, they have a progression or an increase of MELD and child score, and those who survive these 9 months or who live longer, they have a better evolution of MELD and child score. So I'm coming to the conclusion of this registry study. The alpha pump can expand therapeutic options for cirrhotic patients with refractory ascites. The continuous drainage of ascites in a closed-loop automated system led to a significant reduction in paracentesis frequency. And last but not least, there are technical problems, but technical and procedural improvements are required to reduce the rate of adverse events and reinterventions, and some of these improvements we already have at hand. So these are the sites that participated. Of course, it is not possible to do it as a single center, but this is the work of several investigators, centers, and thanks to all these people listed here, finally this publication had been or has been successful. So thank you very much.
So thank you very much also from my side for this opportunity. I would like to share with you our burn experience, maybe from a clinical, practical point of view. And of course, I'm open for suggestions and questions. And we started with the first pump, with the first implantation of the pump, of an alpha pump in May 2012. Totally, we had 45 patients. It's equivalent to 7-8 pumps per year. So it's an operation you don't perform every week. And 71% of the patients were men. And five pumps are currently still ongoing at the moment. And 11 pumps were explanted at the time of a liver transplantation. and 3 patients are alive with an explanted pumps now, and 26 patients died with the pump. So, as we heard before, of course, the main indication for the alpha pump implantation is refractory ascites in the setting of liver cirrhosis. Most of our patients are present an alcoholic or hepatitis C cirrhosis, but we also had a case of one patient with a cardiac ascites and one patient with metastatic breast cancer. Of course, since many years in a stable disease. Otherwise, we wouldn't perform the operation. But this was an interesting case, and usually the patients we include present a clear contraindication for a TIPS. As we all know it, maybe the most famous contraindication is hepatic encephalopathy, and also some patients with a dysfunction in TIPS. And a few patients came to us with an explicit wish, and they were patients still working and not able to tolerate an hepatic encephalopathy. So now, what kind of complications did we encounter in this experience? Initially, the common problem, as we heard before, is the blocked peritoneal catheters. But since Sequana developed the new catheter, this problem is much better. And the patients presented some general infections. Local wound healing problems are very rare and not so severe. And also very rare cases of pump dysfunction, easy to solve, changing the pump. And close to after the operation, we had some patients with macroscopic hematuria, and in our opinion, we suggest to sit it out and wait, and all these patients stop bleeding by themselves. And of course, an important point is the renal dysfunction after the implantation. And of course, the renal dysfunction is less severe and easier to control with aggressive terlipressin and albumin therapy. Yeah, so these are 2 pictures. I think old pictures. This was the peritoneal catheter with the clot, with probably omentum maius piece closing the last hole of the catheter. It was probably the Sequana nightmare, but also for us, but in the last years. But now with the new catheter is much better, of course. And here you see the peritoneal catheter is floating free in the abdominal cavity, and in this case was floating, probably placed also behind the spleen to avoid to encounter the omental tissue. So what are we trying to do to be successful with alpha pump implantations? We have a small dedicated team, so very small and very dedicated, as you know, and of course it's very important the teamwork. So we suggest not to work in isolation. We also involve nutritionists and infectiologists in case of infections. And for every surgery, of course, it's very important to choose to have a good indication and to choose the right patient. But maybe for alpha pump, it's even more important because it's a kind of a special surgery with a special patient population. Now, and well, how do you choose the right patient? The patient has to have a recurrent large volume refractory ascites, and candidates who don't qualify for TIPS. And the patient selection for the indication is done by experienced hepatologists and surgeons, also with experience with patients with severe liver diseases and dysfunctions. And we suggest preferably in a center with liver transplant experience or associated with a liver transplant center, of course, because some of these patients are also listed for liver transplant. And for a patient, it's important to understand his illness and the mechanisms. even more than in other surgical indications, and has to be motivated and of course very compliant, and then be compliant, for example, to charge the pump. Also, if it's very easy, but the patient need to charge the pump frequently and come to the follow-ups. Exactly, and in case of recurrent hepatic encephalopathy, of course, we need a good family support. Yeah, and what kind of contraindications do we have? As well, for the absolute contraindications, we find the current urinary tract infections or spontaneous bacterial peritonitis or untreated urinary outflow obstruction and the loculated ascites. And relative contraindications are the history of previous UTI or SBP and multiple previous abdominal operations with adhesions in the peritoneal cavity. And exactly, so this. And choose the right, very important is to choose the right timing and delay surgery if it's necessary. If there is a problem, I would like to say, especially in the nutritional situation of the patient, better to delay surgery or to postpone, especially postpone surgery and optimize the nutritional situation of the patient. Exactly. So now I come to surgical tips and tricks from a practical point of view. What we do is not the same day surgery. The patients are admitted one day before, and we perform an ascitic drainage, and we leave 1-2 liters in the abdomen. Exactly, and then we perform some diagnostic on the ascites. If we see signs of SBP, we postpone the surgery if we have any doubt. And of course, also we have to check the kidney function, and that's because we use very early in the postoperative phase teliprecin and albumin with the help of our hepatologist, of course. Exactly. So very quickly, the schematic view of the alpha pump. The alpha pump is placed in the subcutaneous tissue. It's attached to the abdominal wall, and we have the peritoneal catheter pumping the ascites to the bladder. This is what the planning of the operation. The alpha pump comes into the right upper part of the abdomen. This is the suprapubic incision for the urinary catheter, and this is the supraumbilical incision for the peritoneal catheter, and this is the incision for the pump. Exactly. This is an example of the connected pump ready to be placed in the pocket, and this is the suture. The end. So for the intraoperative part, we recommend to fill the bladder very well with methylene blue saline solution, and maybe 400 or 500 milliliters. And if the bladder is not clearly palpable because of insufficient ascitic drainage, we suggest to remove the ascites first, and then also consider the ultrasound guided puncture if necessary to avoid any intestinal lesion. Exactly. For the puncture of the bladder, we go directly suprapubic, and we didn't see any problems with the catheter dislodgement or misplacement in this position. And also for the supraumbilical midline incision and the peritoneal incision, we suggest to perform a very small incision because this patient, or let's say this abdominal wall and the skin are used to variate in the size and are very flexible. So with a small incision, you gain a good access normally. And exactly for the pump incision, we recommend to cut higher than the pump, not directly over the pump, and the pump pocket should be not too big. Otherwise, in the days after surgery, the pocket will feel with ascites, and if it's too small, if the pocket is too small, you have a problem with skin erosions. Exactly, and we close all incisions with subcutaneous sutures and of course with skin sutures. Then we start in collaboration with our hepatologists with a pumping volume of 800 milliliters per 24 hours directly in the operating room. So and also we recommend not to combine with other procedures like hernia, etc. Only perform the pump implantation. And in our opinion, it's not an ideal teaching operation because it looks easy, but small mistakes, maybe a suture not placed in the best way, or not paying attention to detail can result in big problems for the patient. Exactly. So in the postoperative phase, we suggest to leave the skin sutures longer than normal, about 3 weeks, because these patients with liver cirrhosis are healing slowly. And of course, always use terlipressin and albumin or in indicated cases. What we perform also prophylactic norfloxacin, long-term antibiotic treatment for all these patients. And very important is initially in the postoperative phase are very regular and close follow-ups with the pathologist and with the surgical team, and especially to control the renal function and the wound healing. And if the patient presents a strange feeling in the skin like electrical pain, then it's, from our empirical observation, it's useful to reduce the pump volume. So then, if the patient presents a problem after the operation, then the first point to know is to relax, and then less is usually more. It means don't be too aggressive with a revision or too active, and observe the situation and speak with your hepatologist and try to optimize the volume manage, and if possibly add 1 or 2 more skin sutures on the skin, and increase the pump volume to 2 liters per 24 hours to empty the abdomen. And then the skin will also heal with the time. And exactly, resist to surgical revision is also our recommendation. Probably, yeah, especially in the early phase. Then later it's another point. But and exactly, and once the patient is home, very important are the follow-ups to control the wound healing and the renal function, as I said before. So if the patient presents a local pump infection, try and seed it out, maximize the conservative treatment with a large spectrum antibiotic, or but wait with the revision, and unless the clear clinical indication, for example, severe infection or sepsis, do not remove the pump too early. A lot of cases, or most of cases of these patients were healing with antibiotics. Exactly. And if possible, only exchange certain parts of the pump, for example, the peritoneal tube or the bladder catheter. So this is our suggestion, but we can discuss it later. And exactly. So very often we use longer-term suppressive antibiotic therapy, especially in patients not going on to have a liver transplantation. Exactly. These are 2 examples of skin problems. This was a local infection of the pump, and we treated this patient with antibiotics, and he could heal without problems. But this patient received antibiotics for 2 or 3 months at least. And this is another case many years ago with a patient coming, coming from home with the alpha pump exposed on the skin. And at the end, we tried to treat this patient with antibiotics and adapt the skin, but at the end we had to remove the pump, of course. And so, in summary, what can I say? It's before the implantation, very important is to assess the nutritional status and start a nutritional support therapy, if necessary, also with a nasogastric tube. And at the time of implantation, I would like to highlight that to ensure it's important to ensure the abdomen is flat and not under tension. So remove the ascites 1 day before surgery, replacing, of course, albumin, and use terlipressin with your hepatologist after the pump implantation. Exactly. So now, if you want to see an implantation or present or send us a patient for an evaluation, you can contact us. Thank you very much for your attention. If you have questions later.
Okay, thank you. Thank you, Sequana team, for allowing me to present our experience in Geneva with the alpha pump. As you know, this is quite basic consideration, but when a patient has clinically significant portal hypertension, he is exposed to many complications, and one of these complications is visceral bleeding, hepatic encephalopathy, ascites, which will be the topic of today, and of course renal insufficiency, which is some kind linked with ascites accumulation. And this is very important to remind that your patient does not have only ascites, but he has ascites on the top of cirrhosis, and other complication has to be kept in mind when treating such a patient. So I will go quite briefly with this overview because Professor de Gotardi already explained you what is recurrent and refractory ascites. We have to remind that hopefully a minority of our patients with cirrhosis go to recurrent and refractory ascites. And this minority of patients have to go to second and third line therapy. And third, that is large volume paracentesis, optimizing diuretic if possible, and discussing some drainage, like internal drainage with the alpha pump, and also intermittent external drainage, such as with the Prorix catheter, but will not be addressed today. And always think that your patient may be a candidate for liver transplantation. And tips also has, in my opinion, has to also to be considered. So that's why when we are facing a patient with such a problem, we have to consider many options with him, with the team, with the doctor, with the family. And I remind you that TIPS is a good solution for refractory ascites, but in addition to hepatic encephalopathy, which has been cited before, other problems contraindicate TIPS. And this is age, because age is directly related to the risk of hepatic encephalopathy. Also cardiopulmonary problem. If your patient doesn't have a good heart function, you should not insert a TIPS in this patient. And of course, as Andrea told you, complete portal vein thrombosis is a major technical problem. But another issue is that when your liver is very atrophic, if you make a portal flow diversion by the TIPS, you may precipitate hepatic atrophy and promote liver failure, liver insufficiency, and your patient will die. So all these things has to be taken into consideration when deciding what is the best strategy. So the different strategy, as I said, has to be considered. And if you choose large volume paracentesis, you have to be aware that some complication may supervene, such as renal failure, infection. You do not have any action on visceral bleeding, and you probably don't have any action, and you probably have your patient going to further malnutrition and sarcopenia with repeated large volume paracentesis. If you choose TIPS, You have to remind that your patient will be exposed to liver insufficiency and hepatic encephalopathy and some problem of dysfunction which can appear over time in spite of this new generation prosthesis. And if you choose the alpha pump, you always have to be aware that your patient will be exposed to some degree of renal failure, infection, dysfunction of the system, and he's not any protected against visceral bleeding, so you have to keep that in mind when you follow these patients. And these slides summarize the different options, and as I said, this external intermittent drainage, the pleuric system, well, I will not talk about this today. So, how do we see a patient with alpha pump in Geneva? So we started to consider the patient for such a system if he has large volume paracentesis at least twice a month. He should ideally have a moderate liver failure, as you have seen, child B, but sometimes child C, it's possible. TIPS should not be an option in these patients. And of course, the anesthesiologist should be okay, and biologically speaking, the patient should have too low platelet count with regard to the surgical operation. And from a medical point of view, serum creatinine should be below 150. As you heard, this is the abdomen should not be multi-operated for some technical reason. Patients should not be infected. Recently or ongoing infection, and he should not have aerodynamic problem. And of course, he should also be able to handle the smart charger for charging issue, of course. So I will summarize for you the itinerary of a typical patient as we do in Geneva. Of course, first I meet the patient and we discussed of many options, the risk and benefit ratio of the system, maybe the necessity for abdominal imaging study, maybe a visit to the urology specialist in terms of aerodynamic problems that may supervene, or if we're not sure about any urinary obstruction problem. The patient then visits the surgeon. The surgeon will meet the patient, see if it's technically possible, inform the patient, and also he may also inform the patient of the possibility to make a surgical repair of an umbilical hernia during the same operating time. Then he visits the anesthesiologist to evaluate the operative risk, correction of possible coagulation disorder, and the patient comes to hospital the day before with a large volume paracentesis, as had been said just before, complete workup for infection, in particular ascites, and we really try to optimize renal function, making sure that the diuretics will have been stopped, and taking the opportunity of having the patient in hospital to give albumin and try to reach this threshold, empirical threshold of above 30 grams per liter of plasma albumin. So this is some pictures. We start with, have been given by Wojciech Sajevic, who is a surgeon who started a program in Geneva, and we start with a urinary catheter with a suprapubic incision. Then we prepare the pocket in the abdominal wall, and then the peritoneal catheter is inserted. If there is an umbilical hernia, it has to be, it can be repaired during the same times. And you see that the catheter is tunnelized and directed in the place where the pocket will be, where the pump will be installed. Both catheters are ready for connection, and the pump is inserted in the pocket in the abdominal wall. So after this intervention, which lasts approximately the same in Bern, it's about an hour, I'll try to remove the bladder catheter as soon as possible for an infectious reason. And then I instruct the patient and the nurse about how to use the smart charger. The pump is usually set up during the surgery. usually at very low volume. We start at a low volume and ready to increase maybe the day after, but progressively. I again take the opportunity of having the patient during these 5-7 days in hospital for a close clinical and biological surveillance in terms of infection, electrolytes, renal function, etc. And again, giving albumin, trying to approach this threshold to try to preserve as much as possible the renal function. I make sure then the antibiotics, norfloxacin, is administered since the operation, and of course, I make sure that this treatment is continued after the patient leaves the hospital. I see the patient then 10 to 15 days after, just to see how it is, to remove stitches, to perform lab tests, to adjust maybe pump parameters. And then I do not advise the patient for any salt-restricted diet or restriction on hydration. And of course, no diuretics. So really, they are free. Their only job is to make the charging as well as possible, but they are not restricted in anything, only on alcohol, of course, for alcoholic liver disease. What about follow-up? So the patients are regularly seen at the outpatient visit for every 4 to 6 weeks for lab test, pump volume if necessary, and systematic albumin administration. I give systematically 80 grams, that is 4 vials, every 4 to 6 weeks to this patient. And this makes my administrator happy because they see the patient back to hospital sometimes, and it makes me happy because I see the patient and I can make sure that renal function is mostly preserved, or I can adjust the pump volume if necessary. That's why it's important to see the patient, and if there is renal dysfunction, decrease the daily volume, maybe with the help also of a strong IV vasoconstrictor, that's telepressin, which helps to improve serum creatinine in the setting of this acute kidney injury. If the ascites is still prominent, is still a big problem, we can increase, of course, the daily volume. And we also have to keep in mind that there should not be pump or catheter dysfunction, but we have this auto-report Sequana to make sure that the pump is working well. If any symptoms, such as pain or hepatic encephalopathy, very important to look for infection, particularly on the skin where the charger is inserted, but of course on ascites. And it's important not only to collect ascites in the urine, but to make diagnostic paracentesis. Suspicion of liver cancer or cancer depistage, remember no MRI because the device is not MRI, possible. And always check that your problem of, if the patient has esophageal varices, it has to be checked. Remind you that the alpha pump is not doing anything to protect your patient against visceral bleeding. So you have to keep that in mind. So I chose to illustrate some clinical cases which give you at most our experience in Geneva. And I start with one of the very first patients, a 55-year-old man, alcoholic cirrhosis, abstinent, MEL12, Child-Pugh-B, history of portal hypertension, but the varicose bleeding has been eradicated. He has refractory ascites. He could not get a TIPS because of severe liver atrophy. He was in poor nutritional status, and he had large bilateral inguinal hernia. Biologically speaking, low platelets, moderate coagulopathy, albumin moderately decreased, serum creatinine 110 micromole per liters, slightly elevated bilirubin, and no infection in the ascites or anywhere else. So we perform such a classical checklist for this patient, and we see that this patient has no contraindication for alpha pump implantation. And our objective for this patient were, of course, to reduce the need for large volume paracentesis. He was, I think I will show you that on the next slide, he was dependent of about 8 liters every 2 weeks. since many months. So we wanted to reduce the need for paracentesis. We wanted to improve the nutritional status, to improve, of course, the social wellness, and to try to bring him to surgery later on for the very big inguinal hernia. So this was the aim of the device. And these slides show you, summarize you the evolution of this patient. He had approximately 5 liters every 2 weeks, 5 to 6 liters every 2 weeks since at least 6 months. We implanted the alpha pump, and of course, as I said, I gave him regular albumin. This is a little mistake too. The albumin was administered was able to keep him between 20 and 23, 24 grams per liters of albumin during follow-up. We started with 900 ml per day and progressively improved the volume pumped every day until 160, 1.5 liter per day. He was doing very well. You see there is no major deterioration in renal function. And this patient had a very long time, 1,350 active days on alpha pump, and he was really doing well. He improved in his nutritional status, and he was able to go later on to the surgeon to get his hernia repaired. So this is important, speaking of malnutrition, because as you have heard today, malnutrition is a very severe condition associated with refractory ascites. And this scan of this patient at baseline shows you that he has he's very poor nutritional state. He has very little fat, parietal fat, and you know that sarcopenia can be evaluated by measuring this psoas muscle. And you see that both of these parameters speak in terms of a very bad nutritional status. And 6 months later, after pump implantation, you see that he gained some fat, some parietal fat. We hopefully see the alpha pump here. And you see that the psoas muscle has gained some volume. So this patient has obviously, and also based on images and on objectival parameters, has gained some good things in terms of nutrition. So the second patient, she's a 47-year-old woman, abstinent alcoholic cirrhosis, refractory ascites again. She's dependent of 6 liters paracentesis every 10 to 15 days. And in spite of some diuretics that are given to her, but she has some side effects. And with these pictures, she's addressed to our Center for Liver Transplantation. And she had experienced spontaneous bacterial peritonitis the months before. She's evaluated for liver transplant in the setting of MELD-15, Child-Pugh B9, esophageal varices, severe portal hypertension, and moderate to severe malnutrition. So she's evaluated. We decided to feed her with enteral nutrition, with a nasogastric tube, and to implant the alpha pump. The alpha pump is implanted. We start at 700 ml per day, and we assisted after several weeks of a moderate increase in serum creatinine up to 114. But we decided not to adjust too much the pump. You see that the pump, the daily volume is 1 liter per 8, which is quite a high volume for our program. And she did well, and months after the implantation, she improved the nutritional status. She gained almost 2 kilos of good kilograms. I mean, no water. It really good tissue. And we are able to stop the nasogastric tube. She had better appetite, only mild residual ascites, and we were able to decrease the volume. And finally, last summer, the pump was switched off. But the patient didn't want the pump to be explanted, so she still had the pump, but this is not working anymore. And she will probably be delisted for liver transplant because she improved very much. Okay, another patient, one of the early, also early patients, 67-year-old woman. Again, it's probably biased in Geneva, but alcoholic cirrhosis again. Child-Pugh B, MELD 11, very important refractory ascites, very atrophic liver, contraindication to TIPS, evidenced by this atrophic liver, and very poor nutritional status. She's in hospital since 2 months, and she's not able to leave the hospital because of repeated paracentesis. Biologically speaking, you see the renal function is preserved. There is no major liver failure and no ongoing infection. And again, with this checklist, what we wanted for this lady was mostly to decrease, if possible, to abolish large volume paracentesis and to improve status, and of course, to give her the possibility to leave the hospital and to return home. And this was the main objective for this lady. And what happens is everything went very fine for this lady. She had the pump implantation, regular follow-up and albumin supplementation, and the volume could be gradually increased to 800 ml per day, and she had no more paracentesis during follow-up. And you see very long active period on the alpha pump system. She was able to go home. She was very happy, and this is very a success of the alpha pump in this lady. More challenging. This patient, 68-year-old male, against Geneva cirrhosis, abstinent. He's living in an institution. He is Child-Pugh C, MELD 17, so he's more sick. And a problem, he had recurrent hepatic encephalopathy. He's not a liver transplant candidate. We could not, of course, discuss TIPS because of hepatic encephalopathy. And a problem of ascites is a major problem. Since 6 months, he's dependent of large volume paracentesis, 8 liters every 10 days. Another problem, he has chronic renal failure, initially 150 micromole, but we were able to get him back to 140, and also large hernia. So this gentleman is not in very good shape. We see the low serum albumin, high serum creatinine, moderately elevated bilirubin, but no infection. So here again, we made our checklist, and what we see is that we were not very happy with this patient because he had severe liver failure, he had chronic renal insufficiency, but we decided the survival was expected more than 3 months. He had no major other problem, and the anesthesiologist was quite happy with this challenge, and he was okay to go for the alpha pump in this gentleman. So the main objective in this more severe patient was to really decrease the need for large volume paracentesis, because it was very difficult in this institution to perform repeatedly this procedure in this patient, and this patient was really fed up with this paracentesis. Well, the procedure was not easy, not quiet, but we expected it. We started with pump implantation, and the day after, he developed acute renal deterioration. We decreased the volume. We infused terlipressin and albumin. We were able to get back to baseline value in terms of renal function. And he went back to his institution with this daily drainage. He had some paracentesis necessary because he was not charging very well the device. But during one of these paracentesis, he experienced an acute complication of paracentesis, which is a hemoperitoneum, and he was again hospitalized. During this hospitalization, we decided not, in spite of the deterioration in renal function, we decided not to modify the volume transported by the alpha pump, because the priority was really to decrease as much as possible the need for paracentesis in this man. And he went back to an institution, and during the almost 6 months of follow-up, he had only 7 of these paracentesis, and he finally died of liver failure and hepatic encephalopathy. So this was a particular case, but illustrates what you really want with the alpha pump, and this is a question of risk-benefit ratio that has been discussed on a case-by-case basis. So this female is listed for liver transplantation in the setting of child B alcoholic cirrhosis, refractory ascites, again 8 liters every 10 days. And she was implanted by the alpha pump, and we started at the volume, which correspond approximately to the ascites produced every day based on the previous paracentesis. But you see that very early after that, we observed an acute deterioration in renal function. We decreased the pump, the volume. There was a slight improvement in the renal, in serum creatinine. We raised again the volume to 700 ml per day. But again, you see we observed a very severe liver failure in this cirrhotic patient. So we decided to silence the alpha pump. We went back to baseline value. We restarted at a very, very low volume, but in spite of this, we went again to very moderately elevated serum creatinine. And in this setting of a patient waiting liver transplantation, we know the importance of getting to liver transplantation with a normal or as normal as possible renal function. We decided to explant the alpha pump, and she was back on regular paracentesis, and she was transplanted 2 months after. Okay, so the last patient, she was also waiting for liver transplantation, almost similar to the previous patient. She started with 800 ml per day, acute deterioration, necessity for terlipressin and albumin, regular, of course, albumin during follow-up. But in spite of this regular albumin infusion, she experienced another acute deterioration in renal function, and then again terlipressin albumin, and then another complication, and this time was infection of ascites and urinary tract. And for this reason, again, we decided to explant the pump, and she was transplanted many months later. So what is the summary of our experience in Geneva? So we had 22 patients, as you've seen, mostly alcoholic cirrhosis, mostly child B, but 1/3 of the patient had child C, severe liver function, mean age 59 years, majority of male. 9 patients were candidate for liver transplantation. The mean number of paracentesis before alpha pump implantation was about 3. Active days on alpha pump for patient was 233 days. Average liters removed per patient, 126 liters. Average daily mobilization, 690 ml. And what about technical problems? Well, initially we had some, what I call relatively minor problems with the first generation catheter. But since the new generation catheter, we don't have any more problem. We experienced one bladder catheter dislocation on the day after surgery, which necessitated another surgery, but now it's completely okay. Due to pump dysfunction, charging or communication of the pump was not working, so we had to exchange a pump 4 times. The total liters of ascites removed in Geneva was 3,760 liters. The follow-up of this patient was 347 days. During follow-up, 5 patients had no more large volume paracentesis, and 17 had occasional paracentesis with a mean number of 5 per patient. The problem was renal dysfunction. We had acute kidney injury of stage 1 or above stage 2 in 5 patients, and it was reversible upon pump adjustment, terlipressin, albumin, etc. But in 4 patients, we experienced a severe liver impairment called the hepatorenal syndrome, which was reversible in 2, but non-reversible in 2 patients. What about infection? 10 cases of infection, 7 due to ascites, 2 in urine, and 1 skin infection next to the pocket of the pump on the abdominal wall. What about local complication? 1 dehiscence 0, infection 0, and 2 large hematoma that were spontaneously resolved after 2 weeks. Pump explantations, 13 in our 22 patients, 1 because it was useless, because the patient was, he was treated for his chronic hepatitis C infection, he improved, and we could explant the pump. 5 because of infection, and 2 because of renal failure, and 5 because the patient received a new liver. What about the outcome? 10 out of 20 are alive. Among these 10, 5 have been transplanted, but 12 died. So what have we learned from this experience in Geneva? The alpha pump system is really helpful to control ascites. It improved the quality of life, the abdominal comfort with regard to both the ascites and the umbilical herniae that often accompanied the refractory ascites. We were able to improve the nutritional status. I've shown you an example of these obvious changes in sarcopenia and parietal fat. It's possible to have a pump implantation in advanced cirrhosis and in patients with liver transplant candidates, but we have to be very careful in this patient. We have to balance the benefit in terms of nutrition, but the risk in terms of renal dysfunction, and I remind you it's very important to go to liver transplant with really the best possible renal function. What about albumin supplementation? You have heard that it's still an unresolved issue, but I decided to put this patient on regular albumin supplementation during follow-up in Geneva. And it's not completely, I mean, it's based on some observation. In the first sub-study by Rajiv Jalan in London, we see a non-significant but clear signal in terms of changing in plasma renin activity following alpha pump implantation. And in a more recent experience from a team in Barcelona, in 10 patients, you see that after 1 week, 1 month, and 6 months, there is an increase in the plasma renin activity and in norepinephrine concentration in this patient after alpha pump implantation. So we may think that alpha pump may mimic this so-called post-paracentesis circulatory dysfunction, and until the question is more resolved or is more clear, we keep this patient in Geneva until on regular albumin supplementation. Thank you very much.
So good afternoon, everybody. My name is Lisa Barker, and I'm the Clinical Education Manager for Sequana Medical. So today, I'm just going to take a few moments to discuss the reimbursement for alpha pump here in the Swiss market. But before I do that, I would like to just take a few minutes to discuss about the clinical training and support that we do give our customers here before I then go into the reimbursement slides. So here at Sequana Medical, we firmly believe that training and education to be an important foundation. For me, it's the cornerstone in what we do in order to deliver first-class customer-focused support. And this is achieved with a team of experienced professionals who hold a wide range of skills. Our clinical specialist team provide on-site guidance, coaching, and support to hospitals, working very closely in collaboration with our customers. Our extensive offering includes support from expert clinical team during the lifetime of the alpha pump, And our message for you today is to say that we are always available to support your needs. So we have experience now with the alpha pump for over many years, and what we've learned is that through preparation and planning, the patient outcomes are much improved. So we do offer a lot of different training options, and we think about, especially for new centres, those that will come into contact with a patient with an alpha pump. So we have a dedicated on-site training upon activation of new centres, but we also offer a Centre of Excellence programme. So what that actually is that we have a couple of centres here in Switzerland who will invite hepatologists and surgeons from new centres, and they can go through presentations about their experience, like you've just heard similar today, and also the opportunity to see alpha pump implantation in the OR. We also offer extensive physician and ward nurse training, and also pre-implant surgical training, and that's to include not only the surgeon, but also the OR team, especially the scrub nurse too. So when it comes to the actual first implant itself, we do have 2 specialists in the OR, so we can actually deliver support to the surgeon and also to the scrub nurse. But not only that, we offer a proctorship programme. What that means is that we have the availability of an experienced alpha pump surgeon to be present in that first implant. But our training and our education don't just start and end at the implantation process itself. We do offer a wide range and post-implant training programme for the physicians, also for the nurses, but most importantly also for the patients, so they can go home and look after their alpha pump. Let's start again. Okay, so going back to the last slide. If I just go forward to the next one. So as I say, we do offer some post-implant support, and this is continual, ongoing customer-focused support. We have a team of engineers back in our office in Zurich, and they're there to offer technical assistance for anybody with the pump, but also our data analysis team. And what they look at is the pump data, and that allows them to respond very quickly and effective to any changes they have with the pump data itself. And you, the physicians and any of the surgeons, you can receive weekly pump reports, and I have an example there on the right, and that has the sort of key parameters that shows you the pump data itself. And what they can do with that is, for example, they can alert you of any issues. For example, if a patient has decided, or they haven't actually got any pump data, say for 2 days, then we will actually alert you with the emails, and that allows you to contact the patient to see if there's any issues there. But also, we very much like to work very close with our hospitals in order to help with troubleshooting. We do this proactively in order to solve any problems. So going on with the post-implant support, we're very much committed to the development of further guidelines and reference materials, and we do that with our most experienced centres, with the hepatologists and surgical expert panel meetings. And what they do then at the moment is they're looking at things like the patient selection criteria, what to be mindful when selecting patients for the alpha pump. We're also trying to really fine-tune our implantation process so that we're creating less variables from centre to centre. We're also helping with the post-implant patient management, and I think you've got some really good experiences from both Bern and Geneva today. But with that as well, because we're creating a great network of expert panel meetings with the hepatologists and surgeons, is that new centres can have contact with these experienced centres to guide you through any part of the process that you have when you want to embark on an alpha pump implantation programme. So with that, I'm just going to jump straight into the actual reimbursement of the alpha pump for the Swiss market. Just a couple of slides just to give you some guidance. So it's great news that the alpha pump is covered by the Swiss DRG system. That actually came live earlier this year. And what I've got here is a little bit of an example how to get to the DRG. So the DRG is basically derived from a combination of the CHOP code, the procedure code, with the diagnosis of the patient according to their condition, And we've put those inputting into the coding system. That comes out with the DRG code here. So it's absolutely imperative that you always use the CHOP code when coding the procedure in order to get the right DRG code. And what's great is that with the DRG code, it's not only covering the cost of the alpha pump and the catheters, etc., but also of the procedure itself. So the anesthesia and the bed, etc., etc. So for my final slide, just giving you a little bit of an idea in terms of the length of stay with these alpha pump patients. So we do actually have an average length of stay of just under 8 days. But as you can see here, the time period of the DRG reimbursement goes from 3 days to 17 days. So it doesn't matter if your patient stays in for 6 days or for 9, 12 or 15, the DRG amount is exactly the same. Of course, there are the differences in the trim points, so if a patient gets discharged less than 3 days, the DRG reimbursement is slightly decreased, and more so, if a patient stays in a little bit longer for whatever reason, there is a slight increase in that DRG. But that is it in a nutshell. So I think really what's to remember is as long as you put in the CHOP code with the patient's diagnosis according to their condition, then you'll get the DRG for reimbursement for the alpha pump. So if there's any other questions or you want to contact us to discuss not only the DRG, but also our training and education offerings in Sequana Medical, please visit us at the website at www.alphapump.com. But thank you very much for listening, and I'm going to hand over now to our next speaker. Thank you.
Here we go. Hello, my name is Jeroen Kapel. I'm the head of clinical affairs. As said before, most of our patients are cirrhotic patients, mostly due to alcoholic liver disease, hepatitis. I'm here to tell you a bit more about our experience in other indications from clinical trials and case reports. These will be malignant ascites, pleural effusion, cardiac cirrhosis, Achilles ascites, and yellow nail syndrome. On malignant ascites, we're currently conducting a clinical trial. It's retrospective, so it is patients who have been implanted in the past, and we're collecting data. The Instellhospital in Bern is collaborating in that, London Hammersmith, the Royal Free, University of Leipzig, Bonn, and in Stuttgart. The primary objective is to see if the patients benefit from the alpha pump. Does it do provide relief? Safety and tolerability, hospitalizations in frequency and duration, duration of treatment, etiology, and outcome. We have some preliminary results. Those patients have been implanted in the past. So the ascites is secondary to malignancy. Most frequent malignancies are ovarian cancer and breast cancer. And about 50% of the patients sufficiently improve to tolerate further treatment cycles with cytostatic medication. So far, about 30 patients have been implanted in the past. And these had an average survival of 201 days, and the range is 5 days until 835 days. So that's a very large range. 19% survive for less than 1 month. 31% survive between 30 and 90 days, 16% between 90 and 180 days, 90% between 6 months and 1 year, and 16% survive for over 1 year. We have started data collection, and we expect to have a manuscript ready by the end of this year. Pleural effusion. We have done a study with Professor Stoel from Marseille and also Bristol in the UK, collaborated on that. We've included 2 patients until we decided to halt the study because of lack of recruitment. We started in 2012, and all 2 patients were included in France. So the first patient is a 60-year-old female with a secondary pleural malignancy. She was implanted the 2nd of September 2013, explanted on the 2nd of December 2014, and during that time, 19.6 liters was pumped. The second patient, a 54-year-old female pleural malignancy, secondary again, was implanted in 16th of February 2015, completed 1-year follow-up the 2nd of February 2016, and during that time, 35.2 liters was transported. Both patients died due to a disease progression. We're now currently working on a manuscript and on the study report, which should be ready until the end of this year. Cardiac cirrhosis. This has been some time ago. We again intended to do a 2-patient study in Sweden this time. And the people who are familiar with the pump might not recognize what we've got here. We have an entirely different catheter, and this is the charger. First patient was male, 57-year-old, CHF right side, edema, not a candidate for heart transplant because of poor kidney function. Class 2, early class 3, patient had pacemaker. Patient was implanted for 4 months. During the time, 17 liters was transported, and patients needed to have an explant because of infection. Second patient, 65-year-old male, chronic ischemic heart disease, previous myocardial infarction, prior bypass surgery, not on the transplant list again due to reduced kidney function. Paracentesis every 4 to 6 weeks, class 3 to 4, again with a pacemaker and also suffering from diabetes. Patient was also implanted for 4 months and during the time on 150 ml per day, and also implanted due to infection. This was a study in 2008 to 2009. That was before we recommended the use of antibiotic prophylaxis. Due to the infection, the study was halted. Gyrus ascites as such is not an indication. We don't know exactly how many patients that have. We've seen it positively in 7 patients, but probably in more patients. Currently, 2 patients with Gyrus ascites are active. It didn't cause any pump failures. The viscosity is higher, the power consumption is a bit higher. No practical implications there. The longest a pump has been active in such a patient has been 50 months, and in those 7 patients, we have 80 months active pump life. An interesting case which was brought forward to us at an expert panel meeting, and that's yellow nail syndrome. It's one patient, it's not a study, it's a case report. A 61-year-old female with yellow nails, and you can clearly see that. Patient builds up ascites, about 800 ml per day, and hydrothorax. She needed a weekly percutaneous puncture. Pump was implanted December last year, and this is from the latest implant weekly report. Has been implanted almost 10 months now, and since that time transported 183 liters, 88 liters. Patient is still doing fine, and yeah. So in summary, the alpha pump is intended use in patients with refractory ascites due to liver failure or malignant ascites for palliative use. We plan to share information on malignant ascites trial by the end of this year, hopefully published early next year. We have done some clinical studies in cardiac cirrhosis, pleural effusion, but with very few patients and very limited anecdotal experience there. Physicians have used the alpha pump also off-label. Yellow nail syndrome implanted and successful. We recently were approached for a patient with lymphatic duct injury, traumatic. That is under consideration. Patient also has Gyrus ascites. Thank you for your attention.